guys so much for coming to my in-service on esophageal surgery. I am joined today by Dr. McCarter, who's one of our oncology surgeons on our Green Surgery Service team. He specializes in gastrointestinal cancers, and he will speak to us specifically on esophageal surgery. And then Sarah Funk is our clinical dietitian, and she's going to talk to us about how the nutrition looks for the esophagectomy patients before they come in, during their stay, and then after they go home. All right, so I'm going to let Dr. McCarter start.
All right. Well, thanks very much, Kat, for putting this together, and it's certainly my pleasure to be here and try to educate you a little bit about what esophagectomy is all about. Every talk has to have your objectives, so these are our objectives today. And I just thought I'd start with a little bit of background about esophageal cancer, and just to let you know there's about 18,000 cases per year in the U.S. It's far more common in men than women, and it's very much associated with reflux and Barrett's esophagus. And reflux is also associated with increasing obesity. The symptoms of esophageal cancer are often very difficult to discern, and that's why it usually presents as a very late stage. Things such as difficulty swallowing, anemia, blood loss, or weight loss. About 3/4 of them are in the lower esophagus, and about 50% of them are metastatic at the time of diagnosis. And I just wanted to point out these pictures down at the bottom here. The bottom right here is a normal-looking esophagus. This is an esophagus with Barrett's esophagus, and you see this sort of pinkish, irregular shape, call it salmon-colored. That's a Barrett's esophagus, and that's a change induced by reflux, and that's not supposed to be there, but that's the protective mechanism that your esophagus does to try to mitigate the injury from the acid reflux. And then if it goes beyond that, this is some Barrett's, normal looking Barrett's. If it goes beyond that though, you can start to form a tumor, and that's what a tumor looks like. And here actually you're looking down into the stomach, so it's just a tumor right at the junction between the esophagus and stomach. And historically, this has been a devastating disease. If you take all patients diagnosed with this, only about 17% would be alive in 5 years. That's because so many have presented at a very late stage. But it does differ on your stage. If you happen to catch it early on, this is a local stage, this is a node negative, you do a little bit better. If you're node positive, not so good. And if you're metastatic, then clearly not doing very well. Now, having said that, down the bottom you can see the trends over time. Despite how bad it is now, we actually have been getting better at this. Probably earlier detection, some other better treatments, but we have made some progress. So you'll notice that many of these patients have received some sort of pre-op treatment, either chemotherapy or a combination of chemo and radiation, and that's, again, because they're typically fairly advanced when they're diagnosed. So most patients who are coming to an operation in this country now would get some sort of pre-operative treatment. And that treatment has been proven to improve their overall survival, so that's the good news. It does come with some side effects, as you can imagine. Now, when we do these operations, we have a number of different choices of how we actually conduct the operation, and there are 3 major ways to do it. One is called the transhiatal, another is called the transthoracic, and the third is called a 3-field dissection, and I'll tell you briefly about each of them. It's suffice it to say that the one we do the most of is the transthoracic. And we actually now do this with the laparoscope, and I'm going to show you that in a minute. But basically, the transthoracic has an incision on the belly, an incision on the chest. You remove the part of the esophagus, part of the stomach through there. The transhiatal has a different approach in that we don't make an incision on the chest, and there's some advantage of that. The thoracotomy, the chest incision, is the part that actually hurts the most. It causes the most morbidity. So now, if we do this, we can make an incision on the belly, an incision on the neck. And then you can see that we make a dissection in between there, but the difference is that we do this kind of bluntly. You can see the surgeon reaching up in there into the chest. It's kind of an operation of faith in many ways, but it has some benefits for the patient long term. You'll see a few of those done every once in a while with select patient for that one. And then the 3-field is kind of like the biggest one. We do all 3 areas. There's a few centers that really believe that you need to do a neck dissection, a chest dissection, and a belly dissection. But it's not done all that often. There are a few indications for it, though. So as I mentioned, we have now moved to doing that transthoracic operation with the laparoscopes, and I'm going to show you a video of this in just a second, but wanted you to see just the pattern of how things go here. We start out with some small incisions on the belly, just like you would be doing either a Nissen fundoplication or a gastric bypass. This is very much the way you set it up, with a few incisions. And then we just mobilize all the parts free up the stomach from the vascular supply, and then we create this this tube out of the stomach right here. With the tumor being up here, you're isolating that area. And then when we turn the patient into the chest, we pull the stomach up in the chest, make a connection between the stomach and the esophagus here, and complete this gastric tube. And this is what it should look like when you're done. I'm going to try to show you a quick video. Now, this operation actually takes about 7 hours. But this is a 3-minute video showing you what we first do is take a look down in the esophagus to see where the tumor is, and then we start mobilizing the fat, the omentum, off of the stomach, just disconnecting some of the attachments that would keep you from being able to pull it up in the stomach. This is the spleen over here. We're taking that off the spleen. We're now moving up towards the chest area. This is the liver being lifted up away here. We have to supply, this is one of the major blood supplies to the liver, so we want, to the stomach, so we want to preserve that as we're mobilizing everything. And now we're back, going up into the chest, the liver is up top, and now we're looking at the, what's called the crus, or the hiatus of the diaphragm. Now one of the things we have to do is remove, or take out the left gastric vessels and the lymph nodes along there. That's a stapling device dividing the left gastric artery. And then we're going to go ahead and remove some additional lymph nodes from that area. This is part of the lymph node dissection that's standard part of the operation. And here we are going ahead and making the gastric tube. We're using a stapling device to divide partway through the stomach. We don't divide the entire thing yet. Now we have to prepare to go up into the chest area. And so we're opening up some more room, and now you're looking up in the chest. That's the esophagus. And now, just before we finish that part, we bring up a feeding jejunostomy tube, fix it to the wall. Now we turn the patient and we're looking at the chest. That's the lung. We're dividing some of the, it's called the azygos vein. It's one of the landmarks in the chest, and that's roughly the level that the connection will be made ultimately. So that's the esophagus in the chest being protected with a retractor. Here we use a loop of Penrose drain just to lift that up so that we can better complete the dissection. The esophagus is being held up here, and we're using a device to divide the connection to the esophagus. And once we've got it freed up adequately, we go ahead and take some more lymph nodes from the chest area. Again, the lung. You can see the lung here. That was the esophagus being divided, and there's a stapling device put into the esophagus there. And now we're going to bring the stomach up into the chest. So that's the stomach that we previously prepared from the belly. Now it's sliding up into the chest. We bring a little bit of that momentum with it. And once we get that into the chest, we then orient it. We place the stapler right through here, connect it up to the esophagus. And then we'll fire that device, and that was the connected esophagus, and now we're just going to take off the remnant of the stomach. And that's the specimen there that we're going to pull out through one of the small chest incisions. And you can see the stomach lying in place here, and then we take this omentum and try to protect it. The omentum is your friend up in the chest area, and then that's the chest tube being positioned in the operating room before we expand the lung.
I had a question.
Yeah.
Maybe a dumb question. Why are we taking out part of the stomach?
Yeah, because the tumors are usually right at the junction between the stomach and the esophagus, and you want a margin away from the tumor on both sides, both the stomach and the esophagus side. Yes.
So on your body, just point to us like how far up do you pull your stomach up, or how far it could, depending on where the tumor was.
The stomach can actually reach all the way to the neck, so you can't stretch it that far. When we complete this, it's usually roughly about this level, and we prefer that one because the leak rate's a little bit higher if you go to the neck, a little bit lower if you go here. But either way, it's about the same operation from a cancer standpoint.
And that doesn't cause any, does it cause any, like?
No, it definitely messes with your physiology quite a bit.
Yeah.
That's one of the downsides of the operation, is that you have to give up what's called the lower esophageal sphincter, that muscle between the esophagus and the stomach that's supposed to prevent reflux.
Yeah.
So basically, you take an operation where almost half the people have the tumor because of reflux, and you do an operation that guarantees the reflux. It's kind of a catch-22. But you're trying to get it so far away from the area that was damaged that you're not as much risk of reforming cancer. There's a lot of things we do to try to mitigate or prevent some of that reflux-induced injury, but you can't get away from it. And then as far as swallowing goes, you haven't done anything to the upper swallowing mechanism, so generally that's not so bad. But people do notice that there's a difference in how they eat and how it feels to eat afterwards. And they can, of course, only eat small meals. It's effectively like having a gastric bypass done because you've made a very narrow tube out of that stomach. Okay. So moving on, actually I saw Kat has a slide in here later about the common post-op complications, so we can come back to that later. We also have some things on nasogastric tubes, but I'll just tell you the whys here, and we can talk about the maintenance later. The main reason we use them routinely now to decompress the stomach. You don't want the stomach to get very big and distended, maybe damage the connection. We want to protect the anastomosis and prevent reflux, at least early on. We also place the feeding jejunostomies, and the main reason we do that is that these patients are often malnourished to begin with. They're getting pre-op treatments, and they have difficulty getting adequate calories early post-op. So this is our protection against that. And then the chest tubes evacuate any of the fluid that collects in the chest. If there happens to be a leak, then the chest tube ideally should control that leak. And if we can control the leak, usually we can get them through that problem. If the leak is not controlled, that's when they get very sick. And we try to avoid that at all costs. I did just put a little plug for the university here. We do, probably the majority of the esophagectomies in this state. And if you compare how our patients do compared to the nation, we do very well, especially if you have a very early or late stage tumor. All right.
Well,
and then,
I threw that one in there.
Yeah, thanks. Yeah. We realized we didn't have, so the way things have kind of aligned, there are 6 of us that do this operation, 3 thoracic surgeons, 3 surgical oncologists. We work together. Generally, the surgeons do the belly part, and the thoracic guys do the chest part. And this is the common pairing. This just has to do with common operative days, believe it or not. It just when it worked out, it wasn't any other planning than that. Occasionally, if some of us are out of town, you might see us switch up a little bit. But these are the common pairings. Myself, I work with Mitchell mostly. Edo works with McGee, and Gladys works with White. All right. That's the part.
So the reason we wanted to throw that in really quickly is just so you know, you'll see when Kat presents and on the pathway that there are some things that are very surgeon specific. Specifically, Dr. McGee does some things that Kat will talk about and you'll see on the pathway. But when Dr. Edel is primary, or we see the patient here on the 6th floor, it's still technically a McGee patient, so we may see some of those interventions. So that's why it's kind of important. At least know that Edel and McGee have a little bit different preferences and some things.
Yep. Okay.
You guys can come sit over here.
Oh my gosh, that's wow. Yeah.
All right, so I'm going to be talking to you guys about the nursing pearls that go along with the esophagectomy patients. And you should all have a copy of the pathway that you can follow along with, and we should, through the whole presentation, pretty much brush on everything you guys will see on that pathway, but feel free to ask me questions as I go along. So the nursing pearls that I'm going to be covering are going to be common medications that you guys are going to see, as well as the administration of the medications, care of the nasogastric tube and the J tube, pulmonary health with these patients, care of the chest tube, pain management, and then we'll do potential complications. So copy of the pathway. Lindsay just redid it a couple days ago, and it looks great.
Lindsay and Kristen.
Lindsay and Kristen. All right, so medications. As far as liquid medications are okay to give through the J-tube, no crushed medications can ever be given through the J-tube. So if you were to put a crushed medication through, you have the risk of clogging the J-tube, and then following that, you're compromising the patient's nutrition, since the main source of the nutrition is going to be through the J-tube to start. Oral medications can be started once the patient is tolerating a clear liquid diet. And then pain management is going to be through an epidural or intravenously until the patient is started on clears and can start taking stuff orally. And normally it's going to be Dilaudid is what you're going to see in their epidural or PCA, unless it's contraindicated for the patient.
Can I ask you a question about
Sure.
oral medication?
Yeah.
There was a question with my patient was tolerating clears and oral potassium was ordered, and we were like, is it too big? Is there like a
I think,
limit?
Yeah, that's an excellent question.
Yeah.
In my opinion, if they're tolerating clear liquids and there's no leak, then it's okay to go ahead and give that pill.
Is it like gastric bypass and usually crush the meds before you give it to them?
You don't have to necessarily do that, and some of them, you know, it's hard to do or can't do that. So if they pass it, they don't have a leak and they pass their clears, they should be able to take it.
So that was Magox, right? Magnesium?
It was
Or
actually,
it was potassium?
it was potassium.
Yeah.
So it's big
Yeah.
and
really big.
uncomfortable for people that swallow normally. So I would say question it anytime if you have a question and work with Ike because there's alternatives.
Yeah,
Mhm.
I think we ended up doing
Yeah.
yeah, and how the course should go is they should have a swallow evaluation, an esophagram should be done to look for a leak, and then after that they'll be started on the clear liquid diet. So hopefully they'll be able to pretty much tolerate anything, but yeah, use your judgment. If it's a huge pill, sometimes that's difficult if you haven't had an esophageal surgery, so. And then common medications you're going to see with these patients, you're going to see an epidural, PCA, again, usually Dilaudid. They're going to be on sub-Q heparin, LR, or NS at 125. Liquid oxy through the J-tube. Toradol should be ordered for them. It's 15 milligrams IV unless their creatinine is, I think I did that backwards with the creatinine, didn't I?
Well,
Just say elevated.
Elevated is.
Yeah, elevated. And if they are over 65 years of age, they will not be getting Toradol. And then Colace BID usually started around post-op day 6. And then this is our little note down here for the surgeon pairing. So if Dr. Edel operates with Dr. McGee, you're going to see differences on the MAR with the meds that are given. So they're going to have metoprolol, 5 milligrams IVQ6, and then Duonebs from respiratory are going to be ordered.
Is that metoprolol preventative for,
Arrhythmias. Yep.
so like the VATS patients we used to see when we
Yeah.
were at night? Same story. Okay.
So care of the NG tube. So the main thing with the tubing, whether it's the NG tube or the J tube, is we want to make sure it's staying patent. So we're going to be flushing the NG tube with 30 cc's of water every 6 hours. You want to be cautious when you're flushing the NG tube, not to be pulling or pushing on the tube. So make a note when the patient comes up from the ICU of where the tube is marked, or mark it if it's not already marked, so you know where it should be. And that's a good thing to pass on and report to let the nurse know. You can see the NG tube secured with a bridle, but it's not necessary. Just make sure it's secured on there in some fashion. And then we're monitoring the NG tube for patency, looking at the color and the output. And then low intermittent wall suction is how the order set will be for those.
I just have to interject on
Oh, yeah.
NG tubes. I want it to be known that I hate NG tubes. But we do use them. Yes, most patients hate them too. But if we use them, it's important that they're being used effectively, right? So keeping it flushed is important. The other thing is that air, the blue port, the air sump port, always a good idea just to flush some air through there too. You can't tell you the number of times that I see reflux gastric continence coming back up there. That just drives me nuts, because if that's not something, then the tube's not going to be working well, and then you've taken all the morbidity of the tube and no benefit of it. So, I drill this into my residents, but I think it's important that you maintain it as well.
All right, so cans and cannouts of the NG tube, we talked about this a little bit at our 12 o'clock huddles, but the RN is okay to flush the NG tube with water and discontinue the NG tube with the water. Or I'm sorry, with an order. The RN cannot do any other manipulation. That includes advancing it if it seems to move from that part it's marked on the tube, or putting the NG tube back in if it were to completely become dislodged. So if you see an order for that, you need to be questioning that order, because the NG tube, once it's out, is probably going to stay out.
Probably
if it
so,
were to
and
come
that,
out.
it has to do with the anastomosis, and reinserting the tube can cause more damage than good, so that's a tending level decision of if and when to put it back in.
So care of the J tube, we talked about this, but no crushed medications ever through the J tube. We're going to be flushing the J tube every 4 hours with 30 cc's of water. And so how that's going to work is ideally it should be programmed into the kangaroo pump. And they're going to start the tube feeds down in the ICU. So the ICU nurse will program it into the kangaroo pump for a flush every 4 hours, but it's still good to, of course, double check that when they come up to the floor. And then one other thing we want to add in to just increase the patency of the tube is manually flushing it with a 60 ml syringe once per shift. So we want you to do 30 cc's like when you're taking in their morning meds in the morning, and then when you're putting up the new tubing in the evening. Just make it a habit and make it when you're already, you know, in there and doing something to begin with. And then Sarah will talk more about tube feeds, but they're started in the ICU at 10 mils an hour in the evening of post-op day 0, and then they're going to be advanced by 10 mils per hour every 4 hours until the flow rate is met, which is ideally around post-op day 3. And then the tube feeds will be cycled once the patient is tolerating a diet, and they'll go home on cycled tube feeds. And as far as pulmonary health goes, atelectasis and pneumonia are always potential complications after an esophageal surgery, so good pain management is really crucial with these patients to ensure that they have good pulmonary health. So as soon as they hit the floor, nursing can encourage using the incentive spirometer, turn hopping and deep breathing, early mobilization, up out of bed at least 3 times a day. And then a respiratory therapist is going to be consulted on all of these patients, I believe, and they're going to pretty much do an assessment on the patient, decide if they need further interventions to create for more of a, to create for good pulmonary health with them, and they can order what's called a PEP valve, which we've been talking about at like our monthly meetings. We're kind of just working out the details with this, but it's a positive expiratory pressure device that they will come possibly order for the patient, and we'll be the ones that do it with them. And then no CPAP or BiPAP for these patients, it's just like our GB patients. Care of the chest tube. So the chest tube is going to be to -20 of continuous suction. You want to be recording and documenting the output and site assessment every 4 hours. And then just a reiteration on what we should be assessing on the chest tube. So every 4 hours, vital signs, O2 status, looking if there's an air leak, looking at the water seal chamber, checking the suction, drainage, level of comfort for the patient, insertion site dressing, and checking for crepitus. And then per shift and as needed, we're assessing breath sound. So CT surgery is going to take down the original dressing that's on the chest tube about 48 hours post-op. And after this, a dressing should be applied, Xerofoam, gauze, and foam tape, and then that can be assessed and changed daily or PRN.
I should just add that there are some attendings that don't put their tubes on suction continuously. They might start for 24 hours, but then put it to suction, to water seal.
Okay.
It's a matter of debate amongst ourselves, so just be aware that some people just do straight water seal.
Okay. And Kristen, are we overall seeing all attendings are okay with water seal for ambulation and like tests, or not necessarily? It's individual.
I think we'd have to double check it. I don't know. In particular, Mitchell likes his suction a lot, so I'm not sure. I'd have to clarify that.
So checking with the team if they're going down for a procedure or something, if they can go to water seal, or if we need to order suction for them. And then pain management. So with these patients, nothing by mouth for a minimum of 5 days post-op. So again, they'll have an epidural or a PCA for pain management, and usually Dilaudid. Toradol is an excellent and encouraged adjunctive therapy for these patients. It can be started around post-op day 3 as long as there's no bleeding and it's approved by the attending.
And then these patients often come in with reflux, right? So on medications for reflux?
Yeah.
Post-op, are they on these medications?
Yeah, so this is one of my favorite topics because the operation actually takes out the vagus nerves, which reduces your ability to produce acid by 80-something%. So they actually don't make a whole lot of acid. Having said that, everybody refluxes, and everybody's reflex to reflux is to prescribe antacids of some sort, right? So almost all of them, despite my telling them all this, end up back on some sort of antacid. And whether it's effective or not, nobody knows.
So they will often ask about it at discharge, right, Lauren? Because they're so used to taking their, Prilosec or Nexium or whatever. So it's okay for it not to be ordered when they're discharged.
Right, and so for the reflux that they do have, the agents that are if any, are effective are Pepto-Bismol and Sucralfate, because those are kind of neutralizing agents, coating agents. They're not really working on acid because they're not making a whole lot of acid.
All right, Sarah's going to talk next on nutrition. This is our last piece.
All right. So, prior to, obviously, these patients are possibly not eating well because of dysphagia, or when they've gone through the chemo or radiation, just those symptoms of the treatment. So when we come and see our patients, we are getting a nutrition history from them. We are seeing how they were eating beforehand, weight loss and such. But this kind of impacts their ability to heal if they've had, they haven't been eating well, they've had weight loss. So after surgery, and you can interject if I miss anything, early satiety, and that can come with the delayed gastric emptying, the gastric reflux. So we talked to them really about how to minimize that, which they probably already have worked on with those symptoms of reflux before. If they have a leak, obviously then we're not eating, then we're solely relying on that J-tube. And then we have, they have increased needs for healing, and then they're not able to get enough in as far as eating, so we can also see the weight loss occur. So very thankful that we have those J-tubes in place. Let me see. Oops. So just with the, when we start the tube feeds, they're started post-op day 1. And the goal is to get all of their nutrition until we get that diet in advance. So in the ICU, we'll start those. And usually, I think getting up to post-op day 2, unless it's a larger meal, probably that might take longer. The formulas that we use are just our standard Isosource HN or Isosource 1.5. I think that's the one I prefer just because it's easier once we get them cycled. The rate doesn't go as high. So I sometimes ask that to be changed if they're not. And there's some fiber in there as well, so that's helpful.
Just a quick comment about the tube feeds here. We made a decision to be very aggressive about advancing our tube feeds, so we actually start them, if they're not hypotensive or other medical issues, we start them post-op day 0 that night at a very slow rate. And then the next, actually this should say post-op day 1, if everything's going fine, we start advancing 10 cc's every 4 hours until they hit their goal.
Okay.
So most people are going to hit their goal within 2 days post-op, and we're trialing this out, and it's been a little bit of an adjustment because it's not the way people are used to doing it, but there's a fair amount of literature that supports you should be able to do that in the majority of patients.
Yeah.
I just have a question, are you wait until the patient at go before you discharge the patient? Because at time I thought I see someone going home with the tube feeding and that they're not eating enough.
Oh, sure, yeah. Many times we send them home. In fact, almost all the patients go home with
Yeah.
So you
Sick.
prefer to have them at go before they
Oh,
go
at goal
discharge
before they
now?
go? So typically they get to goal before they're discharged, but then we put them on a night cycle. And then if they're eating a regular diet, we'll maybe give them half of their needs at night when they go home, still eating during the day.
So we'll get them to goal at a continuous rate, and then once the esophagram is cleared, the swallowing valve, and they can start clears, then we'll change them to a nighttime cycle and give them a break during the day. And I go anywhere from 50 to 75% of what they need, depending on the patient. And it's a very small window of time that we can kind of see how they're doing, but it's just kind of as much information as we have. And usually I'm trying to go a little bit on the higher end as well, more for kind of insurance purposes, but.
Yeah.
I might have missed this, but do you place the J-tube at the same time that you do the rest of the esophagectomy?
That's right, yeah.
So do we have to wait for a test to make sure that's in the right place?
No, that's a good question, but no, because we visually confirmed it, you don't need to do a special test for those.
And what kind of tube is that exactly that you're using?
Yeah, so we transition around a little bit. Now, I've been using the, it's actually a JP, the round JPs. In that video, I had a red rubber, and we've gone back and forth between the two of them. There's some pros and cons to each of them.
Sure.
We like the JP.
Is that right?
And the length of it,
They
they've been
clog
longer
less.
before
Was it
they're
the red
out.
rubber that was maybe?
The Red River is just more, you know, like can stretch, so,
Right.
yeah,
Okay.
I don't know.
And most of the time, you guys have the Lopez valve on there,
Mhm.
and that's what we've been using for clamping.
Yeah.
But without that, is there any way to like clamp that too, if they were not to take that Lopez valve off?
You actually, you could just
Pinch it?
pinch back,
Yeah.
tape it down itself, or, you know, a hemostat, you know, if you need that, just to
Okay.
clamp the tube is fine.
Sometimes they'll just stick a buff cap on it.
Or a buff
in the
cap.
OR.
Oh, okay.
I'm trying to work with the OR to see
I
if
know.
they'll put a Lopez, get a Lopez valve in the
In the
OR, so
OR,
he can
yeah.
just put it on.
Yeah.
Yeah.
It's just easier that way
Right,
for everyone.
okay. So most of the time, the patients that have been coming up have been tolerating that diet, the 2 feet advancement just fine. They seem to tolerate the nocturnal cycles. Sometimes some increased bloating, but I haven't seen a lot of it. And as far as, I didn't put this as far as insurance, but sometimes, so when insurance looks at someone that's eating and then also on tube feeds, they say, well, we're not going to cover this because that patient should be able to eat. It doesn't really make sense because that person isn't able to adequately consume greater than 50%. So it depends on their insurance, and so we might get into a case where the pump and the formula is never covered, but the pump and the supplies are not, and then we would just have to work from there. But just so you're aware, that does come up sometimes. So, diet advancement after surgery. So post-op day 5 is the esophagram, and then the swallow it out. So those, you'll stay tuned on.
Yeah, we're working
Okay.
out a new system there.
Okay, so they'll let us know when the diet is advanced, we go to clear liquids, and then I kind of work with them when we cycle that the 2 feeds, and then post-op day 6, if everything's going well, we go to the post-gastrectomy diet that's in EPIC, and that's what it's titled.
You know, many of us actually go to a full liquid diet for a day, so it's clear
Do you?
liquids,
Okay.
full liquids, then post-gastrectomy.
Okay, gotcha. And has that been discussed as far as everyone likes the full liquid, or is that kind
Yeah,
of?
it's,
surgeon
everybody's
preference?
bought into that early on. So clear liquid's the day of the leak, if there's no leak, and full liquid's the next day, post-gastrectomy.
Yeah, so I don't know.
Maybe not, Sarah, but we can address it.
That's okay. So we'll get into the diet here in a second. As far as teaching, we had talked about, you know, when we want you to kind of help everyone learn about flushing the tubes. The thought is to do it more around post-op day 4 when you maybe have less going on, just to you're not worried so much. You have less for the patient to focus on, but we do want them to start learning how to flush their tube. So even if when you're doing it, just if they're paying attention, teaching them that at that point, that's really the biggest part. And then if you're changing to, you know, nocturnal tube feeds, you can kind of show them just the process. But we do teach them. We have a home health care company come in, and they will teach the patient with their equipment, so that pump specifically, and that way they can do more of a hands-on. But I think it's always helpful, the more, you know, more experience they can get, so they're not getting too worried about it. And it just seems there's some outliers that get a little bit worried about it. Let's see. And then the post-gastrectomy diet. So what we do here are frequent small meals. If they're on a room service option, it's up to the patient. You know, they can order as many times as they want, or they can order. It's going to be difficult for them to order up extra because they're going to be limiting their portion sizes. But we want to do that because of that early satiety, possibly delayed empty. I really have them focus on kind of maybe there's a new normal. And I get some of maybe the male patients, they're like, oh, I'm a great eater, don't worry about me. And I'm like, no, you're really going to feel full. This is going to be different. So I really emphasize taking their time, chewing slowly. At the first sign of feeling full, to just hold off and then let their body give them some feedback about what that feels like, because it's going to be different.
Sarah, I have a question. Like, if I want to pull this up, where do I get it? Is that from the canals, like for the post? diets or anything?
No, so we have one that's an outpatient, and we want to simplify that one just to some bullet points. Because the outpatient they get beforehand, and it's very thorough, but just some bullet points that they can have, so. We want to focus on soft foods, easy to swallow, nothing gummy like breads, we restrict that. We do allow some toast just because of that, removing some of the moisture. I have them focus on protein first. If they're going to be limited on how much they can eat, I really want to make sure they're getting protein versus just taking in some applesauce. If that's all that sounds good, we work with what sounds good. Avoiding carbonated beverages, increasing that pressure, avoiding things that are going to make them uncomfortable. Sitting upright at least for 30 minutes after their meals and during the meal, so they're probably used to that if they have history of reflux. And then also we talk about, maybe more acidic foods that might be causing some problems for them, to avoid those. There is some mention of dumping syndrome, which Dr. McCarty told me that he rarely sees, but kind of like with the gastric bypass patients. So if they were to have a lot of simple sugars and then feel kind of that dumping syndrome, but I have yet to see that as well. Are you guys seeing anything different, and I guess complaints or experiences with the patients eating? And then we try to focus on supplements as well. But we have a couple day window, so I just focus more on. It's a little bit hard to visualize, but this is what we give them as far as well tolerated and not well tolerated. And that's in reference to all foods, not just our menu. So kind of a common theme in that asterisk is down below, but is kind of simple sugars that might affect that dumping syndrome. We want to avoid the soft breads, anything that's gummy that's going to be really uncomfortable to swallow. Let's see, any dried fruits, dried seeds, nuts. I really just focus on protein, and then how are they going to get some extra calories, as well as that adding in butter, not long term, but just how do we help them get some extra calories in. I have them focus more on softer proteins, so cottage cheese, regular cheeses. Peanut butter maybe isn't the first thing that they're going to go for. Tender meats like fish, and then I talk to them kind of at home, like if they had a crock pot and things that are just really soft and moist and easy to swallow. Avoiding anything that's really tough, really dry like chicken. Generally, most of their starches are going to be easy to tolerate. Soups. And then as far as fruits and vegetables, things that are cooked, pretty soft and moist, so peaches and pears, bananas, avoiding any skins at this point in time. And then they can get into that post-op, about 6 to 8 weeks is when I tell them to start to slowly add those things back in.
It's like preparing a meal for your infants when they start eating.
Yeah.
Kind of,
Pretty
like
much.
soft everything.
Right. So.
I would just add, I think it's very helpful for the patient to have some sense or guidelines of what to use, but it turns out that patients are extremely variable in what works or doesn't work for them. And so they start out with this, but there's a lot of trial and error. And basically, as long as you avoid getting the calories, and that's what I tell them too, calories count, I don't care how you get them.
Yeah.
That's important. And so, the usual low-fat diets and all the rest that cut out early on. Once they get going up to speed, then they go back to eating a more healthful diet. But and then the whole thing with the dumping syndrome, sweets or some other things can sometimes set that off. We don't see it that often, but I just tell them, look, there's some things that just may not sit well with you, and you have to work around it.
Sure. And I feel like most of these, well, not most, but the ones that have had dysphagia beforehand are already kind of
That's very
following
true.
this. And so when they look at it, they're like, oh, well, I was already doing this,
Yeah.
that's fine.
Yeah.
But the ones that didn't have it are the ones that struggle or seem to just have to adjust more. But
Would that isopure that we use for the gastric bypasses be beneficial for them to start when they're doing clears? Or-
yeah, and we have the fortified clear liquid diet that has the fortified broth and then the resource breeze as well. So, we can can order that right away, or if it's kind of a prolonged time that they're on the clear liquid diet, we can change that. So, and how often do you see, or how long are you seeing your patients with the J tube staying in place?
Yeah, so most of them are in place for about 6 to 8 weeks, and some a little bit longer. Most of them are out by 3 months.
Really?
Occasionally, we have to keep them in longer just if they're struggling.
That's good to know. But it has to stay in at least 6 weeks, correct?
Well,
Or is that correct?
in theory, that's just to allow the tract to mature so that when you go to pull it, you have fewer complications. That's kind of the, but I tell them that too, is that if it's in, it's going to be in for 6 weeks or so.
Right, okay. So that's right.
Any other questions?
Right.
How long do patients stay in the hospital?
Good question.
Yeah, well, so, yeah, you asked a very pertinent question, because Lindsay and I have been working on this project for a while. We didn't know this, but it turns out our average length of stay is 15 days, going back for 2 years. Now that we implemented this pathway, and the last data check we had in October, our stay was about 11 days.
Oh.
So, I think the pathway and just focusing on some of these issues has helped. I can tell you our goal is even better than that, but that's a good start.
So as you can see, there's a lot of gray area where we're still kind of working things out, and I will update you guys as we go along and get more clarity on some of the pieces, so.
Really quick, one thing I didn't see in any of the slides, but I know it's on the pathway, is to make sure that these patients' head of bed is elevated to 45 degrees.
Yes.
Also, I think when we discharge them home, we continue to ask them to sleep
Yes.
with their head
Yes.
elevated.
Yep,
Forever?
yes. Yeah, that message has been delivered, because
The patients have the message,
know it.
I'm not sure that
that we have.
we do.
message, yeah.
And what do you tell them just get like one of those wedges?
A wedge, yeah, or a bed that sometimes we'll write a prescription for a
Okay.
bed that's
Great, we can
flexes.
talk.
Great,
Thank you
job.
guys so much.